First of all, let me welcome you to what is the fourth expert panel meeting that the Medicaid Drug Therapy Management Program has had on the treatment of schizophrenia, bipolar disorder, and major depression. We hope you'll find this meeting enjoyable and interesting. Many of the people that are here today have been here before, so it appears that the benefits seem to outweigh the risks, at least a little bit, because we have return customers. The benefits to this program, the Medicaid Drug Therapy Management Program, are enormous. Every other year we update these guidelines, we refresh the indicators that we use in analyzing pharmacy claims and determining what prescribers we're going to intervene with. And so the updating of these guidelines and those indicators really keeps the program fresh and enables us to say we continue to be evidence-based, maybe more so than any other guideline. I don't know of any other guideline that's actually updated every other year. We do the adults 1 year and we update the children in the alternative year. So the agenda for tonight is three things. The first is I want to review the objectives of this meeting, not tonight, but tomorrow and Sunday, and do that in the context of a brief presentation about the Medicaid Drug Therapy Management Program, so you can see how the work that you're going to be doing fits in. To those repeat customers, I apologize. You've probably seen some of these slides before, but I thought it was worth going over for the people that haven't attended or haven't been here in a while and so may have forgotten. The second thing I want to do is to give you a brief overview of a clinical trial that the program is about to start, and a little bit of the history about how we got to the point we're at. And then the last thing is just a quick review of tomorrow's agenda and sort of the format for how I hope we'll proceed. Let's go through. The Medicaid Drug Therapy Management Program is conducted by FMHI, Florida Mental Health Institute, at USF, University of South Florida, under a contract with AHCA, Agency for Healthcare Administration. AHCA is the state Medicaid agency in Florida, among other things. This is the program goals. For those of you that are not from Florida, these numbers at the top here, that's actually a statutory reference. This program was created in Florida statute in 2005 as a part of what the legislature called Medicaid reform. And these objectives that are listed here are pretty much language right out of the statute. Improve the quality of care and behavioral health drug prescribing based on evidence-based guidelines. So that's sort of a tip-off or best practice guidelines. That's a part of why we're here. Again, this is the fourth time we've been here. Improve patient adherence to medication plans, reduce risk, and lower prescribed drug costs. This is sort of a schematic of the major activities of the program and hopefully some kind of logical flow. So we start with evidence-based best practice guidelines for the medication treatment of major psychiatric disorders. That guideline process also creates things called complex care indicators. We've now renamed them UPMI, Unusual Psychiatric Medication Indicators. So then we use these indicators, and I'll show you the indicators we're using now, but we use them to analyze pharmacy claims for psychiatric medications. In that analysis, we identify physicians, and I'll explain a little bit, identify prescribers that we want to do interventions with, and there tend to be prescribers that hit these complex care indicators or these UPMI more frequently than their peers. Then we continue to do the analysis. We do surveillance to see what's going on with those physicians and all the prescribers in the Medicaid program from quarter to quarter, and we continue to do interventions based on who's identified through that analysis. So the first thing is the guideline development process, rigorous research-based process, which it tends to be, and I think for those of you that are here the first time, when you see the slew of slides from the experts, you'll be convinced that this is evidence-based stuff. developed by Florida's medical community, so while the experts are presenting the research and the data, and they're presenting recommendations for, in this case, changes in guidelines, ultimately it's the job of the panel to vote and decide what they want to do with the guidelines. So it truly is developed by Florida's medical community. We have had some knockdown dragouts over the years about whether something should be included or not, and the experts were kind of arguing against it, but the panel decided to go for it anyway. Hopefully they're educational, user-friendly, and current. So these are the guidelines for adults that we have now and that we have had for since early 2006, I guess, was the first time we went through this process. That's our website that has not only the guidelines, but a huge amount of information, both in writing. Also, you'll notice that our expert presentations are being taped, and they're edited and put on the website. And so there's a huge amount of supporting material on the website. And my colleague Marie there in the back gets credit for the website for sure, among other things. So this is the definition of the unusual psychotherapeutic medication indicators. They're derived from the guidelines. They're data filters that are recommended by you guys. They're practices that are, this is the best definition, I think Rajiv Tandon came up with this, less well supported by evidence and/or may produce marginal benefit and/or increase risk. Generally, therefore, they should be relatively rare, relatively unusual, and they warrant greater scrutiny. So writing prescriptions that hit some of these indicators don't necessarily mean that something's wrong, but it does, in the opinion of the expert panels in the past, justify additional looks to see what's going on and whether it's justified or not. So we use those indicators to do this quarterly analysis. First, we identify patients that got prescriptions in the previous quarter that hit one or more of these indicators. And we use the pharmacy claims to identify the prescriber that wrote those prescriptions. Then we cluster all the patients and prescriptions by prescriber and rank prescribers from high to low in terms of the numbers of patients they treated that got prescriptions that hit these indicators. And then we use that ranking to decide who we're going to intervene with and who we're going to particularly watch on a quarter-to-quarter basis going forward. And obviously, we're picking the relatively extreme outliers in terms of the frequency of these practices. Oh yeah, yeah. This last point is worth mentioning too. This came out of a discussion at one of these meetings where it was pointed out by somebody sitting in the audience who had gotten multiple letters from us, arguing that we really needed to take account, as best we could at least, of the kind of patients that particular physicians and practitioners were seeing, because certain categories of patients are more likely to produce or to justify prescriptions that hit these edits. And so we're now doing peer group kinds of comparisons, docs that work in community mental health centers, docs that work in assertive community treatment teams, who are by design supposed to be seeing the most treatment-resistant patients, often with state hospital backgrounds, and then private practice physicians and primary care physicians. So physicians can see where they fit vis-a-vis their peers as well as where they fit overall. These are the indicators that we're now using. These came out of the last expert panel meeting 2 years ago. Use of 2 antipsychotics for more than 60 days, 2 antipsychotics for more than 90 days, 3 or more antipsychotics for 60 days, and use of antipsychotics above the maximum dose. These came from the expert panel. They also came from a look of a couple of years at the frequency with which these indicators, the whole set of indicators, the frequencies with which they were hit. We had 4 or 5 indicators related to antidepressants. At one time, we had combination therapies across class, and these indicators absolutely dwarfed everything else that we had in the system. And so we started focusing on these. I guess I wanted to mention that because when we do the bipolar disorder guideline discussion and evidence, and when we do the major depressive disorders, I am hoping that our experts and you all will come up with some suggestions for unusual UPMIs for those classes of medications. We focused on these now for a couple of years. We've had some impact. It's not gone away by any stretch, but I think it might be time for us to look at some other things, even if they're relatively low frequency but high risk. So if you would all think about that between now and tomorrow, I'd appreciate it. These are the interventions that we mount with physicians or prescribers that hit these indicators with some frequency. These are in order of intensity, so as you might imagine, larger numbers of physicians get letters that say, "Dear doctor, we've analyzed pharmacy claims. We see you have 5 patients that got 2 antipsychotics for more than 90 days. Here's some literature. Here's the name of the patients and their ID numbers. Here's some literature that we recommend you consider and reevaluate these prescriptions if you think that's appropriate." That's basically the sense of the letter. It's pretty hands-off. For physicians whose practices continue high in terms of hitting these indicators and are not responding to the letters, we've done some academic detailing. This is where pharmacists who work for the program actually visit physician's office, chat with them about the practices, with information about the patients in our records that hit the indicators. We've done medical records reviews mostly with pharmacists, looking at the medical records of patients that are hitting the indicators, especially where the physician says, well, all of my patients are the most difficult, most complex cases of schizophrenia. That's why they're all on 3 antipsychotics. So we at least take a peek at the record to see if there's any justification for that kind of thing. And then the last thing that we started about a year ago is actually face-to-face consultations that are done by double-boarded psychiatrists from out of state. We initially approached a number of physicians in state who initially said, yeah, that sounds like that would be fun. And then they backed off. And so we have somebody coming in from Wisconsin, I think it is, to do this. And after a week of traveling around, he can leave. And he doesn't have to cope with his colleagues giving him a hard time. This is at least one of the stories that I took away from the review of the write-ups that the psychiatric consultant did after doing about 40 face-to-face consultations for usually an hour or more with physicians that we identified. They were all physicians, I'm pretty sure, that we identified that were way high up on the list in terms of numbers of patients that hit these indicators, whose practices had not changed much over more than a year. Okay? And almost uniformly, the treating physicians said, I'm treating so many of my patients with 2 antipsychotics or 3 antipsychotics because I've got the most complex cases of schizophrenia in the whole state, if not the whole country. They're incredibly treatment resistant. A lot of them actually have forensic backgrounds, and not treating them with 2 antipsychotics will create harm or danger to the community. And as I thought about that, 2 separate things occurred to me. One is, based on the psychiatric consultant's review of the cases, he said there are some physicians out there that are treating some very difficult patients, and most everything's been tried, and I wouldn't know what to do, any different than what he or she is doing. So that is the case. So there are some really difficult patients, and some of these docs that we've identified, when we learn more about their practice, we looked at them a little differently. There's a lot of them, when the records were looked at, small samples of them admittedly, there really wasn't much justification for this first thing. But in either case, whether the patients really were difficult or whether the physician just thought they were and they really weren't, underlying the responses from both of them was this. They seemed to truly believe that treating patients with 2 or 3 antipsychotics was more effective.